Good evening, everyone, and welcome to the second lecture of our orthopedic reconstruction review course. We'll speak today about the total knee replacement. So last lecture, we spoken about the hip replacement and biomechanics and basics of total hip replacement. Now, today we'll speak about the knee. I got few feedbacks about the length of the lecture, so we'll try this lecture to be a bit shorter than before, and we'll be very concise and to the point. So let's start. Okay, so I'm Mohammed Hashim. I'm a foot and ankle consultant at Northwest London Friendly Health NHS Trust, and I'm running this course specifically for you. I need you to understand the basics behind the reconstruction to make your reconstruction job or your reconstruction practice very easy and based on a good basic science. So where I come from, Heatherwood Hospital in Ascot. It's an elective hub under Griffith accreditation, and there where you can find all the educational activities and events I run, my educational channel on YouTube, the Orthoxcel platform on the website, and this is the email if you want to contact me. You can contact me on this email. Okay, so today we'll speak about the knee, and before we go to the total knee replacement, we need to understand the mechanics of a normal knee. And to understand the mechanics of a normal knee, you need to understand that we all know, so the knee is femoral condyles and tibial plateaus. And it's a very unique articulation. It is a specific or a modified hinge. So it moves mainly in three planes. So flexion extension is the main plane. It rotates in and out, and it slides up and down. So anterior and posterior. The medial, you need to understand that the medial femoral condyle is larger than the lateral femoral condyle, larger in 2 dimensions. So it goes more distal and more posterior. And as you can see here, if you look on this picture, if we draw a line centered on the transcondylar axis, you can see that this ring is bigger on the medial side in both planes, in this plane and in that plane. So actually, the medial femoral condyle is broader in 2 dimensions. So it is going more posterior and going more distal. The medial femoral condyle has a broader articular surface, and more articular surface means less point stress. And that's one of the reasons for the medial femoral condyle, when you have a varus knee, it takes a long time for this varus knee to progress. On the other side, if you have a valgus knee, the valgus knee progresses very easily. So yes, medial side or varus knee is more commoner, but we will know now why varus knee is more commoner than more than the valgus knee. But what I mean here with the broader articular surface, that because of the broader articular surface, there are larger surface area, so less point stress. That's why when you have an arthritis in the medial compartment, it takes more time to develop than the lateral compartment. That's why you see the varus knee patient after 20 years of the start of the arthritis, but you see the valgus knee within few years. The posterior projection of the condyles is defined as we agreed, 2 circles, 2 concentric circles running on the center is the transcondylar epicondylar axis. And from the transepicondylar axis, if we run the 2 circles, it will be showing you how much is the medial femoral condyle larger than the lateral femoral condyle. The center of the canal is very important point. So you need to understand that the center of the canal is just anterior to the insertion of the origin of the PCL. So when you're doing your total knee, you need to understand that you will find your canal not in the center, but your canal will be just anterior to the origin of your PCL. So it's a more medial and a more anterior than you imagine. And if you miss this canal, number one, you can easily burst the femur. You can easily go through perforate the cortex. And number two, you can easily miss the intramedullary axis, so you can easily miss all the measurement if you are doing a measure resection knee. The posterior condylar line, as you can see, as we agreed, that the medial femoral condyle is going more distal and more posterior. If you look to this knee from axial, so this knee is now bent. If you look to the femur when the knee is bent, you can easily spot that the medial femoral condyle is going more posterior. So the posterior condylar axis is not parallel to the horizontal, but actually it's about 3 degrees obliquity. The one which is parallel to the horizontal is the transepicondylar axis. That's why we use the transepicondylar axis as a reference when we're doing our total knee not the posterior condylar axis, because the posterior condylar line or posterior condylar axis is actually 3-degree oblique over the horizontal. Transcondylar axis, which is or trans to be more like precise, it's the transepicondylar axis, and this is what you see here, which is just parallel to the ground. Then that plays a very important role when you plan your TKR alignment. So when you're doing your TKR, you use an intramedullary reference, and when you use an intramedullary reference, if you follow the transepicondylar axis, you will leave a gap on the lateral side. That's why all of us go to a minimal rotation of the component of the femur, because we're not following the transepicondylar axis. We need it to fit the distal femur, and that's why your cut has to be a bit oblique. That's why you go with some rotation in your condylar and your femoral component. When we look in the trochlea, when we look in the patellofemoral joint, you need to understand that the lateral trochlea is higher than the medial one, because the patella is tending to displace or dislocate laterally. That's why from the haven, the lateral trochlear facet is higher than the medial trochlear facet, and this trochlear configuration plays an important role in the bony stability of the patellofemoral joint. And when you have this trochlea deformed, with a lot of classification, if you have any malformation in this trochlea or under development of the lateral facet, you have a recurrent patellar dislocation. When we come to the other side of the knee, when we speak about the plateaus, so we understand that the tibial plateaus are not symmetrical. The medial tibial plateau is lower at level than the lateral tibial plateau. The medial tibial plateau is more of a concave, with a slope anterior and posterior and horizontal posteriorly. And this is a very important rule for the stability of the knee. If the medial plateau is not in that shape, with a more distally and posteriorly expanding medial femoral condyle, your knee will dislocate with every movement. That's why your medial tibial plateau, I'm not sure can I show it here or not, but if you look here, so basically the medial plateau is lower than the lateral plateau. It's a broader surface, it's more concave, and has a raised anterior and horizontal posterior slope. Tibial slope is very, very important and plays a major role in the mechanics of the knee. The tibial slope is this slope. So actually the proximal tibia is not perpendicular on the anatomical axis of the tibia, but actually going at about 5 to 7 degrees of a slope. This slope plays an important role in preventing the posterior translation of your tibia, so it's helping the BCL function. That's why you have to restore the tibial slope. At the same point, if you don't so the main idea of the tibial slope is to prevent the posterior translation of your tibia, so it's actually helping the function of the BCL. But if you don't restore the slope in the tooth and knee replacement, when you're doing your tooth and knee replacement, if your cut is more flat, you are affecting the flexion gap, and we'll speak about that in a minute. So you have to restore the slope. If you maintaining your BCL or retaining your BCL when you're doing a CR knee, your slope has to be about 5 degrees. If you lose this 5 to 7 degrees of the slope, your flexion gap will be tighter, and you will have an imbalanced gap between flexion and extension. Number two, when you have your slope more flat, so if you go like a 3 degrees or less, you will end by defunctioning your BCL and allowing the tibia to translate posteriorly over the femur. So you have to restore the tibial slope for you to get a normal mechanics of the knee with your total knee replacement. This makes you to be very careful about when you're doing your cut. You remember when you're doing your cut in the tibia, we are using extramedullary reference, not like the femur when we're using intermedullary reference. We need to be careful about the rotation for the patellofemoral joint. We need to be careful about the cut, because we understand that the tibia, that the medial is lower than the lateral, and with the varus, the medial will be lower and lower. So you have to be careful about your cut, how much you will be taking from. Are you taking from the normal side, or are you taking from the degenerated or arthritic side? And you need to be careful about that. A lot of schools, a lot of people, a lot of knee surgeon prefer to take more from the normal side rather than taking less from the abnormal side, because you can reference in the normal side rather than the abnormal side. So rather than you reference on the medial side when you're getting your cut of the tibia, and you like taking 2 mm from the arthritic side or from the medial side, it's better for you to take about 7 or 8 or 9 millimeters from the normal side, because it's easy to reference to the normal side. You don't know, each patient has an individual arthritis. So some patients are really bad arthritis, the plateau, their plateau is absolutely gone. And if you take 2 mm from this, you'll be taking a big chunk from the tibia, and this will end by you putting a big insert, and we will understand why a big insert is a problem in a minute. So when you cut, you need to understand the tibial plateaus, the difference between the medial and lateral. You need to understand the tibial slope. You need to understand the tibial rotation. You need to understand that the tibial cut is better to depend on the normal side rather than depending on the arthritic side. You need to be careful about the rotation. And in this point, I need you to understand a very important point. Rotation of the tibial component is against the rotation of the tibia. So if I externally rotate my tibial component, this is equally, I'm internally rotating my tibia. So I'm maintaining the patellofemoral tracking. Again, this is the tibia and this is the tibial component. When you externally rotate the tibial component, is equally as you internally rotating the tibia. So the tibial tuberosity is moving in. So you actually moving the line of ball of the quadriceps in. So you're maintaining a better tracking of your patellofemoral. And this is a very important point. That's why you have to externally rotate your tibial component to maintain enough internal rotation of the tibia or the tibial tuberosity to maintain a good tracking of your patella. When we speak about the alignment, so we understand that mechanical alignment is the one we're aiming for. We don't aim for an anatomical alignment anymore. We go more now for a kinematic knee. It's a knee with is a good balanced soft tissue, is a knee which is following the mechanical axis rather than the anatomical axis. The normal mechanical axis runs from the center of rotation of the hip to the center of rotation of the center of the hip to the center of the ankle, and normally it should run across the center of the knee or 1 or 2 mm medial to it. That's your normal mechanical alignment, the normal mechanical axis. What if your axis go into varus? And this is the situation when you have a varus knee, you have an old coxa vari, you have an old cubitus varus. If you have a varus knee, means the knee center will be a lot lateral to the mechanical axis, and the lot lateral to mechanical axis means you're putting more weight on the medial compartment of the knee rather than the lateral compartment, and this definitely will end by high stress in the medial compartment, early arthritis, and early problem on the medial side. If we speak about the valgus malalignment, we need to understand that with the valgus malalignment means the mechanical axis is going out, so the center of your knee is going in, and so you're loading the lateral side more than the medial side, and this actually more problematic than the varus malalignment because your medial compartment, the point we raised a few minutes ago, your medial compartment is adapted to get more stresses as your normal mechanical axis is in varus, not in valgus. So if your mechanical axis is in valgus, means you're overloading the compartment which is not ready to get load, and that's why this end by this compartment going to be arthritic very early. If we come to the lateral alignment, so if we're looking from the lateral profile or the side profile, we understand that your knee center is just posterior to the line of the mechanical axis in the lateral. So because it is that normally if your center is behind the mechanical axis, means the mechanical axis forces, or when you put weight, should be hyperextending the knee. What resists that in the normal knee is the posterior capsule and the BCL. What if you don't have a posterior capsule or you have you don't have a BCL? Your knee will be hyperextending, and hyperextending the knee is catastrophic. So you want your knee to be, the total knee, if you're doing a total knee, to be a bit tight rather than being a bit loose. If you get your knee loose, means when you put weight on it, the mechanical axis will be passing far front of the anterior of the far anterior to the knee center, and this will be loading your posterior capsule and BCL. If you have done a BCL substitution, or if you released your posterior capsule to release your flexion gap, this will end by a catastrophic failure of your total knee. On the other side, if your knee is a bit flexed, this means the mechanical axis on the lateral will be passing behind the center of the knee, and this will end by the load will be trying to flex the knee, and that is when the quadriceps force against that. And you have the quadriceps is good enough to maintain the knee in extended position and fight against the flexion malalignment. That's why you may accept your total knee replacement to be in a bit of flexion or tight in flexion rather than being loose. If your total knee is being loose again, this means you allowing the mechanical axis to go in front of the center of the knee, means all the forces is trying to hyperextend the knee. And if it hyperextend the knee, they will end by catastrophic failure of the total knee. There is a question, the angle can be measured from X-ray only or can be observed in the single leg squat? No, you have to measure this on a long film X-ray. So you have to have a long film X-ray centered on the hip, centered on the knee, centered on the ankle, and then you draw a line from the center of the hip to the center of the ankle and see where this will be related to the knee center. In EB and lateral, in EB will be the frontal alignment, in lateral will be the lateral alignment. Okay, so what about the movement? When you start to move your knee, this slide is very important. I need all your attention. When you start to move your knee, we agreed that the medial femoral condyle is projecting more distal and more posterior. So when you look here, you can see that the medial femoral condyle is extending. Medial femoral condyle is extending more distal. That's why it's a pivoting point. So if I put the knee like that, you see that the medial femoral condyle is touching the medial plateau when the the lateral femoral condyle is off the lateral tibial plateau. When you start to bend, this pivot point is fixed, while this is more mobile. So actually, what happened? If you have a look here on the axis, when we speak about the point of contact between the tibia and the femur, medial femoral condyle is the pivot point. This is the intact point. When you bend your knee, if you have a look, you will feel like the point of contact is running posteriorly, and it's more on the lateral than the medial because the medial is more distal and more stable. So when you move like that, this is what we call the femoral rollback. So to understand, medial femoral condyle is relatively longer in both distally and posteriorly. When you start to bend your knee, the point of contact between the knee, as you see in this picture, the point of contact is running posteriorly. And that's why it gives you the idea behind the femoral rollback. Number one, it allows you to flex all the way. That's why you can have up to 140, 150 flexion of the knee. Without this rolling back, your knee will not go beyond 90. Number two, it improves the lever arm of your. So, guys, just mute yourself. So again, the femoral rollback, you need to understand that when you're flexing your knee, the medial femoral condyle is more distal and more posterior. So it's touching or point of contact between the medial femoral condyle and medial tibial plateau is a bit fixed and moves posteriorly as far you flex your knee. This movement posterior, we call it the rollback, and the femoral rollback happen on the medial side less than the lateral side, because the medial side is a pivoting point and the lateral side is just easily rotating or freely moving. This rollback has two jobs. Job number one, it gives you a more range of flexion, so you can flex up to 140 to 160 degrees. Without the femoral rollback, you will not flexing more than 90 degrees. Number two, every time you move the center of rotation to the back, you give a better lever arm for the quadriceps. You give more mechanical advantage to the quadriceps. Okay, how this will reflect on my total knee? I have to have my total knee designed to maintain this femoral rollback. Otherwise, the patient will be losing a lot of his range of motion. And to have that, you can see that the design on this picture, you see the design of the femoral component compared to the lateral component is adapting to do this. So in this picture, when the knee is extending, this is the point of contact between the femoral component and the tibial component. When you flex, you see this point has moved to the back. Yeah, not as normal, not as the natural one, but it still moves to the back. And that's why it gives your total knee a good range of motion. To have this to happen, you have to have a normal bony shape of the femoral condyle and tibial condyle. you have to have all your ligaments and muscles working normally. If you don't have a BCL, if you don't have a stability in the collateral ligaments, if you don't have a normal hamstrings, if you don't have a normal quadriceps, this femoral rollback will be affected and you will not have the normal femoral rollback. Again, the femoral rollback means the point of contact or center of rotation of the knee during the knee flexion move from the front to back. The point of contact between the femoral condyle and the tibial plateau move from front to back, because the medial femoral condyle is projecting more distal and more posterior. Its pivot point is a bit fixed, so it moves few millimeters to the back, while the lateral femoral condyle, because it is freely mobile, it is shorter, it is smaller, it moves more back. So the roll back in the femur happen more on the medial side than the lateral side. This rollback, the idea is, number one, it increase the range of motion, allow the knee to flex up to 180, this 160 to 140 to 160 degree. Number two, increase the lever arm, because it's increase the distance between the center of rotation and the quadriceps. So improve the quadriceps function. And this is very important when you think about CR versus PS knee. CR means cruciate retaining versus PS, which is PCL substituting. What's the difference? If you lose the BCL in the PS knee, you need to understand that the cam will be doing the job of the BCL in anterior and anterior-posterior translation. It doesn't allow posterior translation of the tibia, but it affects the femoral rollback. So the design of the BS has to be rolling back more than normal to compensate for the function of the lost BCL. While in the CR, you have the function running normally because you have still your ligaments and cruciates and collaterals normally. So the femoral rollback happens as normal as it goes. The femoral rollback, if we understand that the femur point of contact between femur and tibia is running posterior, on the lateral more on the medial, so means the femur is moving back on the lateral side more than the medial side. This is by definition means the tibia is rotating in. So you will understand that when we go now, that with flexion your tibia rotates in, with extension your tibia rotates out. Rotates out and in. Why? Because the point of contact between medial and lateral, on the medial side it moves minimally back, on the lateral side it moves more back. This means the femur normally externally rotates during flexion and the tibia internally rotates, and the vice versa when they extend. This will come again many times, don't worry. When we come to the rotation, so axial rotation during flexion and extension, you need to understand what I explained you now. Medial compartment is deeply dished, is concave, has less than 1 centimeter anteroposterior excursion of the tibiofemoral contact point, while the lateral side excursion is about 2 to 3 centimeter compared to the medial side. So it's nearly 2 or 3 times the medial side. This ends by axial rotation of the lateral compartment around the medial compartment pivot by about 30 degrees. And this movement means with every flexion, your tibia is internally rotated and femur is externally rotated, and the other way around. Okay? This takes us to the screw home mechanism. And to understand the screw home mechanism, we agreed that every flexion means that the tibia is internally rotated and the femur is externally rotated, and the other way around. So you understand when you move from flexion to extension, your tibia is externally rotated compared to the femur. Up to you go to tensioning your cruciates and tensioning your collaterals, what will happen? The knee will lock in maximum stability. So when you stand in your knee all the way going out externally rotating, up to a degree it starts to lock. How it looks? It looks by the movement, by getting the maximum tension of the cruciates and collaterals. And for this knee to go to flex again, it has to be unlocked. And the unlocking happens by popliteus muscle. When the popliteus contract, what it does, it internally rotates the tibia and start to allow the flexion. And it's very common when you're standing and someone comes from the back and just hit you in the back of the knee, your knee goes straight away in flexion. Why? Because in flexion and internal rotation. Why? Because he just stopped the screw lock mechanism or the screw home mechanism. Again, to understand, rolling back means the point of contact between tibia and femur is moving to the back, moving back or posteriorly, more on the lateral side compared to the medial side, about 1 centimeter on the medial side during knee flexion, about 2 to 3 centimeters on the lateral side during knee flexion. So by definition, femur is moving laterally to the back, so the tibia is internally rotating. This happens during flexion, and the other way around during extension. So every time you flex, you internally rotate your tibia. Every time you extend, you externally rotate your tibia. When you reach to the maximum extension, means you put all the cruciate and collateral in maximum tension, and this locks the knee in what we call the screw hoe mechanism. To get the knee to flex again, you have to unlock the screw home mechanism, and this is happened by the popliteus internally rotating the tibia and allowing the knee flexion. Hopefully this is clear. When we speak about the patellofemoral, you need to understand that the knee is tibiofemoral and patellofemoral, and is very, very important. And to be honest with you, the commonest cause you will see of a problematic knee, total knee replacement in the clinic is the patellofemoral. To a very recent report from the NGR, the most common cause of revision of knees was patellar anterior knee pain or patellar dislocation or patellar maltracking. So we need to understand the patellofemoral joint. Up till this slide, we understand that the patellofemoral joint has a trochlea. The trochlea has a bony alignment with the high lateral facet compared to the medial facet, and this is maintaining the tracking of the patella and doesn't allow the patella to go out, which it tends to go because the line of ball of the quadriceps is in valgus. And this takes us to what's called Q angle. Q angle or quadriceps angle is actually the line of ball of the quadriceps. So if you draw a line from the origin of the quadriceps, which is the anterior superior iliac spine, to the center of the patella, and draw another line from the center of the patella to the tibial tuberosity, which is the patellar tendon, you will find that the quadriceps is bowling in about 7 degrees valgus. So the quadriceps in normal patient, in normal individual, is trying to pull the patella out. That's why the lateral patellar dislocation is the commonest form of dislocation. So again, to understand that the Q angle is quadriceps angle. It's the line of ball of the quadriceps. And to draw the line of ball of the quadriceps, we draw a line from anterior superior iliac spine to the center of the patella, which is the quadriceps. Then from center of patella to the center of the tibial tuberosity, which is the patellar tendon. And you will see that the relation between both of them, that the quadriceps line is about 7 degrees valgus over the patellar line. Okay, why it is in that way? It is in that way to improve the mechanical advantage, to have a mechanical advantage, to improve the mechanical function. So what is the drawback of that? The drawback of that, it always gives a lateral ball in the patella, so tends to take the patella in a lateral dislocation. That's why you see lateral dislocation of patella more than medial dislocation. What's the normal Q angle? The normal Q angle is about 5 to 20 and is different from male to female. In female, it's more because normally the pelvis of the female is trefoil, is a triangular pelvis. So actually, the anterior superior iliac spine is far lateral. And if you draw a line from a far lateral point to the patella and from patella to tibial tuberosity, the angle or the Q angle will be bigger in the females because of the trefoil triangular pelvis. So this is the Q angle. We agreed few slides ago that the trochlear geometry is a very important point because high patellar facet on the lateral side, low trochlear facet on the lateral side, low trochlear facet on the medial side allow a normal tracking of the patella and protecting the patella from displacing or dislocating laterally. What else after the bony and the Q angle is the soft tissue restraints, and the most important of them is the medial patellofemoral. And the medial patellofemoral, basically, it gives a very good medial strut to support the patella and doesn't allow it to go laterally. And with every patellar dislocation, the first structure you need to look into in the MRI scan is the MPFL. The MPFL is one of the main restraints to stop the lateral patellar dislocation or subluxation. After the restraint, after the ligament, the muscle, the second thing is the muscle, which is VMO or vastus medialis obliquus, this one. And vastus medialis obliquus is the second restraint after the MPFL to maintain the patella tracking normally and doesn't allow it to go laterally. That's why when you have a first time patellar dislocation, you have to send your patient to have a very good strengthening exercise to the VMO. You have to be very clear in your physiotherapy request. Please, I need VMO strengthening to stop lateral patellar dislocation. So patella depends in the normal tracking on normal Q angle, normal trochlear geometry, normal patellar geometry, soft tissue restraint, which is a MBFL and VMO. Same applies for the total knee. So when you're doing a total knee, you need to have a well-formed button, and the button has to be in a proper shape to the femoral component. So you replicate the relation between the trochlea and the patella. You need to medialize your patellar button, and every time you medialize the patellar button means you lateralize the patella itself, so the button will be inside the trochlea, the new or artificial trochlea, so the risk of dislocation is less. You need to maintain or to save your MBFL, because MBFL is one of the primary restraints to avoid lateral patellar subluxation or dislocation. You need to have a proper VMO, strengthening exercise pre and post operatively to maintain a normal tracking. You need to have enough rotation, proper rotation of the femoral component and tibial component to be sure that the patella is centralized or medialized. So you need to have an external rotation of femur and external rotation of the tibia. And as we understand, external rotation of the femur, because this is by definition will medialize the patella, and external rotation of the tibial component, because this means that the tibia itself or the tibial tubercle will be internally rotated. So this is again maintaining normal patellar tracking and preventing lateral patellar dislocation. So if we look in the movement of the patellofemoral joint, screw home mechanism, that's a question. Screw home mechanism provide a few shutdown to the muscle engage. What is the patient loss disadvantage? I didn't get the question, to be honest. What if the patient lose, you mean? If the patient lose this advantage. So if the patient will, you cannot allow the patient to lose this advantage. That's why you need to be careful when you're doing your release capabilities at the end of the release, and the structure, or what's called the configuration, the geometry of the component is allowing the screw home mechanism to happen. So if you look, I have to got, if I remember, I should have got a tibial component, femoral component. If you look in the tibial and femoral component, you see that the screw home mechanism is replicated. And if it's not replicated, the knee will not be that stable. If it's not replicated, the other option is to have a cam box. So we'll come to this in a minute, but in general, the screw home mechanism has to be maintained. If the patient loses the screw home mechanism, this will make the knee less stable in the full extension, which is not allowed, because if the knee is less stable in full extension, the patient will be complaining of functional instability. If we come to the movement of the patellofemoral joint, you need to understand that the patella slides inside the trochlea. It gets engaged with the femoral sulcus at 20-degree flexion, and then after it does that, the center of rotation or the contact area between the patella and the trochlea moves proximally with flexion and externally rotating. As you understand, as we agreed that the Q angle is in valgus to trying to externally rotate. That's why once the patella, once 20 degrees flexion, the patella engage inside the trochlea, start to move, but the contact point start to move proximally and laterally or externally rotated. The contact pressure at the patellofemoral joint, that's very important point to understand, that any mistake during your total knee replacement which end in misalignment of your patellofemoral will end by anterior knee pain, and this is one of the commonest cause the patient will come back to you with. The contact pressure is about half of the body weight when you're normally walking, and it goes up to 2.5 to 3.5 of your body weight if you're ascending or descending stairs, especially on descending stairs. And that's why the patient with patellofemoral arthritis comes commonly to complain from a pain while he is going downstairs. The common question, shall I resurface the patella or not? And I think this question has been answered 100 times. So nowadays, most of the people resurface the patella as a routine, because as I told you at the start of the lecture, one of the commonest cause for revision of the knee is to resurface the patella, because the component, the geometry of the component can be matched with the geometry of a button, but you cannot match it with the normal geometry of a virgin patella. That's why resurfacing the patella gets you away from the area of anterior knee pain and patient coming back with complaint, which will need another revision. And it is calculated as a revision, by the way. How to optimize the patellar tracking? We spoke about that. So you need to externally rotate your femoral component and tibial component. You need to be sure that you medialize your button. You need to choose a button which is fitting the geometry of the femoral component. If you feel that the tracking is not proper, you have to release laterally. If the tracking is still not proper, you may end by doing a tibial tuberosity transfer. but you cannot get the patient off the table without proper patellar tracking. Okay. Then come to the functional stability. So up till now, we spoke about all the anatomical landmarks. We spoke about the normal mechanical stability. Now we'll speak about the functional stability. How your knee is getting stabilized. So we agreed, as any joint, the stability comes from static stabilizer and dynamic stabilizers. In the knee, the static stabilizer is the bony alignment. We agreed that the medial femoral component, medial tibial plateau is concave, broader, and has raised anterior surface and flat posterior surface. We understand there is a tibial slope, which is preventing posterior translation of the tibia. We understand the articular surface geometry. We understand there is menisci, the medial meniscus and the lateral meniscus, and they are fitting the shape of the medial and lateral femoral condyle, giving more stability to the knee. Definitely the ligaments as a static stabilizer, and we know that the main ligaments we are depending on both cruciates and collaterals. We have dynamic stabilizers, which is a coordinated muscle activity, and if you don't have a coordinated muscle activity, this is the time you have functional instability, feeling of giving way, and start to have knee symptoms which is not clearly diagnosed. When you have patient who is coming with sense of giving way, sense of instability, knee pain going on, every investigation, X-ray, CT, MRI scan, everything is normal, you have to think about the functional instability. Proprioception, which is very, very important, especially for the knee, because the proprioception helps in all the mechanism we explained before. The proprioception is responsible for the rollback mechanism, for the screw home mechanism, is for even the functional stability and the muscle balance to maintain the patellofemoral and the tibiofemoral joints. If you lose this proprioception, you are in a bit of trouble, and that's why we advise for a CR knee rather than a PS knee, because one of the main proprioceptive sensors in your knee is a PCL. That's why we advise you always to keep the PCL. And even if you cut the ECL, we advise you to keep the footprint, because the footprint still have some proprioceptive sensation. And without the proprioception, your knee will be functionally unstable. This you need to understand very well. Proprioception is not something simple. It's not just you feel yourself in the air. No, you have to feel where is your joint. You need to feel where is the stability of how is the stability of the joint, what is the area which needs more muscle action to maintain stability, what area needs more muscle relaxation to maintain stability. How to maintain your proprioception while you're doing the total knee replacement. You need to be very meticulous when you're doing your soft tissue dissection. You need to be careful about taking any structure down unless you need to do that. You need to minimize your release unless you need that. You need to lean towards CR knee rather than PS knee to keep the PCL, which is one of the causes of your proprioception. You need as much as possible to leave the ACL footprint to give you some proprioceptive function. Primary and secondary stabilizer is nothing new for you. All of you knows them. When we come to speak about the tibia, we spoke about the femur, we spoke about the rollback, we spoke about the screw home, and now we speak about the tibia. Normally, your tibia, as we agreed, moves into flexion extension, internal external rotation, minimal translation, anterior and posterior. So what is preventing your tibia from massively translate anteriorly? The main restraint of this is ACL. Then especially the anteromedial bundle if you flexing your knee, and posterolateral bundle if you extending your knee. Secondary is your iliotibial band, then your MCL, then your mid capsule, lateral capsule, mid-medial and mid-lateral capsule, and at the end is lateral collateral ligament. Dynamically, what's preventing the anterior translation of the tibia is the hamstring. So how we compensate for that in the total knee? Very easily, you need to maintain as much of these structures intact as possible. You have to get the ACL out. So to maintain normal anterior translation, you have to have a proper anterior repair of your capsule. You need to have a proper anterior repair of your quad, and you have as much as you can to maintain a good balanced knee balanced flexion and extension gaps. Posterior translation, what's stopping the posterior translation of your tibia? As we agreed, BCL is the main. Then MCL has some rule in that. Posterolateral corner has some rule in that, and definitely the tibial slope. If you look in this slide, you can spot easily what is repeated in everyone is MCL. So your MCL is not only a restraint against valgus, but it has a rule in anterior translation, has a rule in posterior translation, and we'll see in the next slide that has a rule in every type of rotation. That's why your MCL is a cornerstone. Without an MCL, you have to go to a constrained knee. You cannot depend on the normal mechanics of the knee without MCL. You can sacrifice normally the ACL, you can sacrifice the BCL, you can sacrifice the posterolateral corner, you can sacrifice the LCL, you cannot sacrifice the MCL. If the MCL is gone, means the stability of knee is gone, means the normal mechanics of knee is gone. You have to have a rotating hinge to maintain the stability. You cannot go with non-constrained knee if the MCL is gone. Internal rotation, the main stabilizer against or restraint against the internal rotation is ACL, then the POL or popliteal oblique ligament, and the posteromedial corner. External rotation, the other way around, so the posterolateral corner, and valgus stress is definitely the MCL, mainly the superficial MCL. So you see, we have mentioned MCL in every and each movement of the knee. That's why, again and again, MCL is not an option to be injured or to be ruptured. If the MCL is gone, means the stability of knee is gone, means the only option you have is a constrained knee. So what's the difference between male and female in the normal knee mechanics and basics? We spoke about the pelvis. Pelvis in the female is trefoil, triangular, more broad mediolateral. That's why the anterior superior spine is far away. That's in by a higher Q angle in the female opposite the male. Because of this position of the pelvis, the mechanical axis moves in all the females to the inner side. So the center of the knee is out on the outer side. That's why they all have a greater knee valgus angle. So the female, especially the sporty female, when they come landing from height or jumping or doing anything, they land on the knee in a valgus position because the mechanical axis is actually far lateral than the normal male. They have low muscle balance or low muscular balance or muscular, you can say muscular, can say it in what way? It's not coordination, but like a coordination. So less muscle coordination. They have lower hamstring activity and greater quadriceps activity. So actually the knee in the females are not that balanced like a male. So the hamstring is weaker, the quadriceps is stronger, so it tends to anterior translate the tibia, and that's why you have to have your knee properly done in a female, and that's why you see females, firstly you see females with more arthritis, and that's why you see more females with more problematic knees, because knee mechanics has to be meticulous in females. There is a range of acceptance in male, but in female it has to be very meticulous. In female, you have more knee abduction and adduction moment. And because more adduction and adduction moment, that puts a lot of stresses on the knee. That's why without a properly aligned total knee replacement, you are in a position to lose your total knee and have a catastrophic failure. Definitely the females, especially if they are all females, the bone quality is not the greatest. You need to be very careful while you're putting your intermedullary reference for the femur. You need to be careful about your cut in the tibia. You need to end in the tibia on a cortical bone, because if you cut too much from the tibia and end on a cancellous bone, there is a very big chance for the tibial component to sink inside the tibia. You need to be careful about the bone quality when you're dealing with females. Over all of this, your females comes to your clinic with some more problematic knee, but they tend to be more happier. They tend to have a better outcome because almost they have a bad arthritis. So if you compare male to a female, pre-operative and post-operative, male gets arthritis less than female on a longer period than female, on less complaint of than female. Female come with a lot of complaint. That's why they have a better benefit and better outcome after the operation, but they still more problematic. This was the normal knee, the anatomy of the normal knee. When we come to speak about the total knee replacement, we need to understand that we have a lot of total knee replacement. The main classification for our total knee replacement implant is the constraint. Is my knee constrained or not? And to what degree it is constrained. The commonest primary knee we're using every day is unconstrained, which could be a unique compartment, could be a CR knee. And this is depend on the normal soft tissue balance, normal soft tissue mechanics, normal mechanics of the knee. and it's just you just resurface the femoral surface and the tibia surface, but everything in the knee other than this is very normal. Semi-constrained means it allows constraint or allows restriction of movement in one plane, like the BS knee, which doesn't allow the anteroposterior movement. So because of the Kaman box, it doesn't allow anteroposterior movement, but it allows all other movement. That's why we called it semi-constrained. Same for a rotating platform. It's different from a rotating hinge. Rotating platform allows the movement in axial plane, but it doesn't stop. Stopping the movement in axial plane, but allow the movement in every other direction. Constrained knee means it have a full mechanical stability in the implant itself, and you use it when you have lost inherent stability in your knee, especially if you lost the MCL. The biggest example of that, rotating hinge and full hinge and TC3. You need to remember that it's a balance. If that's just the constrained knee is maintaining stability, is good, is compensating for any lost inherited stability, we're using constrained knee. Every one of us will use constrained knee for normal knees, for primary knees. No, it's a balance between the constraint and the failure. Every time you get a constrained knee, you put more stress on the implant cement face or interface. Every time you get a less constrained knee, you maintain normal knee mechanics. You depend less on, or you stress less the interface between the bone and cement. So the balance between how much constraint you put and how much stress you go to the interface. With every knee non-constrained, you depend on the normal mechanics. You put less stress on the stem cement and cement bone interface. When you increase the constraints or become more constrained, means you put more stresses on the bone cement and cement stem interface, and you get less normal mechanics of your ankle, of your knee. I'm sorry. So balance between how much constraint is your knee and how much you put stress on the interface and how much you lose from the normal knee mechanics. Less constraint, more knee mechanics, and less interface stress. More constrained knee, more stability, but on behalf of less normal knee mechanics and more stress on the stem cement. I'm sorry, component cement and cement bone interfaces. The commonest design we use every day is a BCL retaining knee, which is a CR or cruciate retaining. As we agreed, this is just a replication of what we said. It maintains your normal knee mechanics. You still maintaining a native BCL. You still have a normal femoral rollback. You still have good stability. The surface doesn't need to be have a very conformity, because you're depending on the normal knee ligaments and muscles stability. So it depends on the dynamic stabilizers. But the problem is it has some coronal plane left off. The coronal plane left off coming from, as we agreed, that the medial side is more distal than the lateral side. So there's a bit of coronal plane left off. The other thing, it has some edge loading because you put the stress on one point. When you're doing a femoral rollback, there is a 1 point contact between the femur and the tibia. And because it's a point contact, it's increasing the edge loading and cause early failure of the plastic. The BS knee is, as we agreed, is a semi-constrained because it controls the anteroposterior translation of the tibia because there is a Kaman box. But on the other hand, it doesn't have the normal ligamentous stability of the knee. So you have to have a more conformity of the surfaces to maintain the stability. And you go for BS knee, especially if the patient gives you and complain of he has mid flexion instability. The mid flexion instability depends completely on BCL, and if the patient have a mid flexion instability, you have to go for a BS knee. Definitely the constrained designs, no everyone use it unless you are a revision knee surgeon, I'm sorry. And it is, as we agreed, more constrained. It depends completely on the implant to maintain stability of the knee on behalf of the normal knee mechanics, on behalf of higher stresses between the component cement and cement bone interface. When you come to the design of the condyles, if you come to the design of the component itself, the ideal total knee replacement, as we agreed, has a good conformity on a way that maintain a femoral rollback and maintaining a screw home mechanism. So you try to minimize the contact stress, but at the same time to replicate the normal knee kinematics. More conformity, better movement, more stability, but on the other side, more stresses on the interface and early risk of loosening. And on the other side, less conformity, especially with the CR knee, gives you a more freely moving, depend more on the normal knee mechanics and less stress on the interface, less loosening and failure. What about the polyethylene? The polyethylene in the knee is ultra high molecular weight polyethylene. Again, it's the one in the hip or away from the one in the hip, which is highly cross-linked polyethylene. The ultra high molecular weight polyethylene, it is more stronger in mechanical properties, but the the high cross-linked polyethylene has a better wear properties with less mechanical properties. That's why the high cross-linked polyethylene goes to the hip and do a good job, and the ultra high molecular weight polyethylene goes to the knee and do a good job. If we put in the knee highly cross-linked polyethylene, yes, wear will be less, but on behalf of less mechanical properties, and that's why the plastic in the knee will be failing. That's why we don't use a high cross-linked polyethylene in the knee, but we use ultra high molecular weight polyethylene. The other way in the hip you need more less mechanical advantage on behalf of better wear properties. That's why we use there a high cross-linked polyethylene. In the knee, no, we need more mechanical advantage of the poly rather than the wear properties. That's why we use a ultra high molecular weight. Never use a polyethylene thickness less than 8, because if you more than 8, I'm sorry, because if you use more than 8, you end by high contact stresses, and if you depend a lot on the plastic, and this plastic will end by a fatigue failure, or what we call delamination and catastrophic failure. Definitely, the polyethylene, we understand the difference between the ultra high molecular weight ethylene and high cross-linked polyethylene in the way of manufacture, way of sterilization, and way of storage. And as I explained, we need a high cross-linked polyethylene up in the hip because we need better wear properties without good mechanical properties. On the other side, on the knee, we need a more better mechanical properties, even if the wear property is not the best. That's why we use ultra high molecular weight polyethylene in the knee, and we use high cross-linked polyethylene in the hip. So what is the advantage of all what we mentioned till now? All what we mentioned till now is how for you to make a properly biomechanically aligned total knee replacement to have a good result. So you need from your total knee replacement to restore the mechanical axis, both in EB and lateral. So you need to maintain a frontal mechanical axis and a lateral mechanical axis. And I explained you, if you put your mechanical axis in hyperflexion extension or flexion, what will happen? If you put your mechanical axis in varus or valgus, what will happen? So you aim to regain the mechanical axis of the patient, to put the knee in a kinematic position, good soft tissue tension, proper mechanical alignment to get the best results. You need your cast to be perpendicular to the mechanical axis, not the anatomical axis. We do the anatomical axis for the tibia because, as all of us know, the difference between anatomical and mechanical axis of the tibia is nearly unnoticeable. You need to preserve the joint line. If you move your joint line up or down, you're actually playing with the patella. So if you go with your joint line up, so you cut more from the femur and less from the tibia, you will move the joint line up. This means you make the patella baja. And if you do the other way around, if you cut more from the tibia and less from the femur, you will move your joint line down, and this will end by a patella alta. You need to balance your ligaments, especially if you're doing a CR knee, because without balancing your ligament, this means more instability, and micro instability on the total knee replacement will end by failure. You have to have a rigid and durable fixation of your component, and all of us nowadays is using cementing component, but uncementing component are in the market and getting more developed. Your surgical consideration when you're operating on a total knee replacement: firstly, your tibial bone cut, as we agreed, we have to be just a sum up. You need to be perpendicular to the mechanical axis for a proper and even loading. Your tibial component rotation is critical. If you mal-rotated your tibial component in internal rotation, you will end by patellar maltracking. Your femoral component, remember that the epicondylar axis is actually 1 to 3 degree external rotated over the neutral axis or the posterocondylar axis, and you need your femoral component parallel to it to be in the optimum. You can draw this by a cross line between the white side line as a vertical line and posterior condylar axis. You need your ligament balanced, and you have to have your ligament balanced. You have to do a proper bone cut. You have to start with a proper soft tissue release. Don't go too crazy on the soft tissue release, and don't go too little or too more will end by imbalanced soft tissue. The varus knee, if you want to release in the varus knee, you have to start for varus or valgus. You have to start with removing the accessory osteophyte. You have to get the osteophyte away. Then in the varus knee, you start to release the deep MCL because the MCL is doing the job. Then you go to the posterior corner, semimembranous posterior capsule up to you release the PCL. In a valgus knee, it's other way around. Again, you're removing the accessory navicular. The accessory osteophyte. Get the osteophytes away. Then you can release the lateral capsule, iliotibial band. Either you release it or make a Z lengthening. Then you can release the popliteus, the LCL, intermuscular septum up to release the lateral head of gastrocnemius. BCL function, we say it 100 times from we start. BCL is mainly taught in flexion. It mainly prevents the posterior tibial translation. It allows the femoral rollback. In BCL retention versus the BCL sacrifice, we agree the difference is how you maintain the mechanics of the knee. With CR, you're maintaining normal mechanics of the knee. You don't depend a lot on BCL. You depend a lot on BCL or and tibial slope. On a BS, you don't depend a lot on the BCL. You can get a 0 degree tibial slope. You depend mainly on the Kaman and box mechanism, and you depend on the quadriceps. Patellofemoral, again, you need to choose an implant design which is fitting your femoral component. You need to be sure that the dome is enough to eliminate any rotational malalignment. You have to put it anatomically. You have to medialize your button, and you have to be sure the tracking on table. You have to be sure you have proper tracking on table. To optimize the patellar tracking, we spoke about this. The patellar height is depending mainly on your joint line. If you raise your joint line, you do a patella alta, baja. If you drop your joint line or lower your joint line, you do a patella alta. How TKR fail? So commons to have a TKR failure is polyethylene wear, and the wear here will not be like the hip in the hip. It's just where particles coming out and causing osteolysis. Here the wear will be a catastrophic here or delamination of the polyethylene. This will happen dramatically if your knee is not balanced, if your knee is malalignment either in varus or valgus, and definitely if your polyethylene thickness is less than 8 mm. Backside wear is again one of the same wear modes we spoke about in the hip. So if you have a backside wear, it will be on the non-articulating surface of the tibial insert, and this happens if you don't have a proper locking mechanism, or if you have third particle or a few foreign bodies between your insert and the tibial component. What increases the loosening? The loosening in the total knee replacement, flexible implant, small contact area, load transfer at the edges, and any features concentrating stresses, like as we agreed, putting the knee in more varus, putting the knee CR knee, which is with less conformity. All this will help with increasing the stresses and causing the knee to fail. Thank you so much. I hope this was on time because I had the feedback from the hip lecture that it was very long. I hope this is on time. I'm trying as much as I can to keep it in an hour. Please feedback after we finish the Zoom. You will have a feedback on the screen. Please put all your feedback because this is how I will improve the course. This course is mainly for you. Please ask all your questions. I'm very grateful to Gemma, if I'm not wrong, who was or were asking questions during the lecture. Please, if you have anything to ask, I'm more than happy to answer. Anas, you can reach the recorded lecture on my YouTube channel. It's called Hashim's Educational Channel. On YouTube. And this is my email if any one of you needs any help or needs anything to be clearer, or something is not clear in the lecture and he needs to have it more clear. I'm more than happy to answer you. I hope it will be helping each one of you to have a more better understanding of the total knee basics and biomechanics. I will see you again in 2 weeks' time on a Friday as well at 9 p.m. London time. I think this will be second Friday of August. So 2 weeks from today on a Friday, 9 p.m. London time. The lecture will be on the YouTube once it's ready within today or tomorrow. And I will see you in 2 weeks on Friday at the same Zoom link. I'm not changing the Zoom link. The Zoom link is a recurring Zoom link. So you need just to come through the Zoom link, and I will see you in 2 weeks on a Friday, 9 p.m. London time. Thank you so much for attending, and hopefully it was up to the level you think about it. I'm waiting for your feedback, which will be once we finish the Zoom. And I wish you, all of you, a very pleasant evening, and see you all.